2.
Hello, everyone. Welcome to our very first live stream here at Eclipse Unscripted. I am your host, Dr. Leek, and many of you know me. If you're new to the channel, I am a pain management specialist. So tonight, again, we're having our first live, and I got to say, I went into the studio tonight, and I was quite impressed. This actually is our conference room, but thanks to Mr. Producer Kevin here, he really did turn it into something special. Thank you, Kevin.
You're very welcome.
No, awesome. Thank you. So perhaps many of you saw the recent live, or actually it wasn't a live, it was a pre-recorded conversation I had with Keith Johnson and his group that he represents, Invisible No More. So I wanted to take this opportunity because I actually had a few days to sort of sit and think about how that went. And I just wanted to actually respond to it. So that's what we're doing tonight. So if you are coming in, welcome. I see some comments down here. Hello, everyone. Thank you for showing up. Kevin, you got your first shout out there, buddy. That's awesome. No, but for real, I do want to highlight really the work that Keith is doing. You know, I've known him for some time now, and I can tell you he really is a caring guy. He lives this stuff personally, and he has a lot of friends, and he's talked to a lot of people who are going through the same thing. And he really does care a lot. So if you are following Keith, you are very lucky to do so. And if you are not following Keith, then you definitely need to check out his group, Invisible No More. I think there can be a wealth of information there to help the chronic pain patient. Now, on that note, again, what I wanted to spend this night doing here right before Christmas is highlighting really the difficulties of being a pain patient. And I just wanted to show you that, wow, after talking with Keith for as much as I have here recently, I am really blown away, to be honest. A lot of the things that I'm hearing is a surprise, to be honest with you. And I think some of that is because I've been in private practice, you know, since I've graduated from fellowship. So I haven't really seen the whole system from all the different angles, but now I think a lot of it is sort of making sense. And of course, you know, I could talk about as well, you know, the difficulties of being a pain doctor, right? Certainly it's not easy in today's environment. In fact, I didn't always know that I wanted to be a pain doctor. I actually thought maybe it wasn't a good idea based on a lot of the stories I was hearing from my attendings and my professors. The patients can be very difficult. The prescribing can be very challenging. You have a lot of governmental agencies breathing down your neck. And if you do something wrong, a patient could slash your tires or you end up getting arrested, right? So it's a very challenging field to go into. But once I got into it in the training aspect, I realized, wow, here's a place where you could really make a difference. And so to hear people like Keith and his movement come to the table as well, I think this is where the real magic happens. And that's why I want to keep this conversation going. And hopefully we can get a lot of good and help a lot of people. So to begin with here, you know, it's no secret pain management can be very divisive. You have on one side of the fence a group of people who are very adamant about the use of opioids, right? And that's sort of their whole movement. You're not a good doctor if you don't prescribe opioids, right? And then, of course, on the other side of the fence, if you even bring up the idea of opioids to a patient, they'll sort of shut you down as being a pill pusher and just wanting to get people addicted, and you're part of the problem, right? So that's sort of the balance that we all have to strike. And I can tell you it's not very easy to do. You know, unless you're having that open discussion where it's like, yes, there are good treatments and maybe not so great treatments, but it really just depends on the patient and what circumstance they're going through. So it's really not that one side is right and one side is wrong. It's really just about individualized care. And I think that is the whole crux of the issue right there. And that's one of the reasons I appreciate Keith and talking with him, is because he understands that. He understands that what treatment might be good for one patient could be deadly for another patient. And in the same way, maybe one patient's already had 17 epidural injections, right? So maybe that's not the best treatment for that patient, moving forward. So I think there's definitely a middle ground to be struck there, and that's the whole purpose of, I'm sure, what Keith is doing. Although I don't want to speak for him, but that was my interpretation, and certainly that's my mission here as well, coming at it from, let's say, the other side of the fence. So, when did pain doctors and pain patients become so at odds with each other, right? When did our relationship become so adversarial? It really shouldn't be that way, but it is. I've heard it. I see it. And now it's being highlighted, right? I think that's a real shame, because it doesn't need to be that way. And pain doctors are really supposed to be here helping you. I think there's, again, multiple things that could go into that. One of the challenges I think that could be contributing to why that relationship is so difficult is the fact that we can't measure pain objectively, right? We, as a physician, we're sort of stuck with the patient report. How bad is your pain today, Mrs. Smith? Well, it's 5 out of 10. Well, who am I to say it's not, right? It's 10 out of 10. Who am I to say it's not? And there's obviously challenges and differences between acute pain and chronic pain. A 10 out of 10 pain looks different in an acute pain patient than it does in a chronic pain patient. So how do you measure the real pain of a chronic pain patient? You really can't, unless you just ask them, right? And there's different ways that we can look at the issue. I remember back in residency, I was rotating with nephrology, which is a kidney specialist. And, so they look at electrolytes and fluid balances and things of that nature. Well, I was rounding with this one particular physician and on this patient, and we were talking about this patient outside of their room before we went in. And, the patient had some pain complaints, but we weren't there primarily. We were looking at their kidney function. And so the physician was looking at the sodium levels, and the sodium level was normal on this patient. And the physician said, well, as you can see, this patient's not clearly not in pain. They're clearly not in pain. They must be making it up or exaggerating. Well, how do you figure? Well, their sodium level is normal. If you have someone truly in pain, that would cause a hormonal cascade in their brain and in their body, and their brain would release antidiuretic hormone, which would then act upon the kidneys and cause you to retain water. That's part of your fight or flight mechanism, right? Which you might be experiencing if you're in pain. The more water you retain, the less sodium you have by concentration. So clearly, this patient's not in pain. But while that may be true in theory, there are so many confounding factors that go on to that in truth, right? That could be explaining a normal sodium and really doesn't explain whether that patient's in pain or not. So, these are all the different things that we look at. There's, exam maneuvers, there's, their functional level and depression scores and all these other pain scores that we look at. So, we try to build a picture of that patient. And certainly if nothing's lining up, then, we have to maybe consider the possibility of secondary gain, but that should never be a primary issue. And, I think part of that is just you have a small minority of the population dictating the experience of the majority of the population. And a lot of doctors are jaded, right? That's just the unfortunate reality. They shouldn't be. And, but that is what it is. So I think that's a big reason why there's this sort of adversarial relationship. And, so then what is the solution to that, right? Well, it's communication. That's the bottom line. It's having conversations like this. It's sort of exposing the elephant in the room. Well, it's like, okay, you're acting this way, so I might be feeling this way, but is that right or is that wrong? Let's just talk about it and figure that out. A lot of it is the relationship the patient has with the physician, right? Because if all I can do is take you at your word, then it's really not pain management, right? It's, from a physician's perspective, it's risk management. It's risk management for the patient, but it's also risk management for the physician, the physician's family, the practice, the whole commitment, to get to that point. So that's really what it boils down to. And the way that you minimize that risk and improve the quality of care is by having open and honest discussion. That goes for both patients and for physicians, of course. So let's bring this back. I want to talk about ACE scores because that's sort of what this response is for. What is pain, right? That's the definition. What is pain? Pain is both a sensory, hit yourself, ow, sensory and emotional experience. Both, not a sensory or an emotional experience. It's a sensory and emotional experience. So, and we know this through ACE scores, just being one example, but we have several examples where people who may have high ACE scores, let's say, for example, may experience pain a little bit differently than somebody who does not have high ACE scores, right? And we talked about that in the recent podcast, and I don't think there's any controversy there, or maybe there shouldn't be any controversy there. That's pretty well documented. Now, I think where the problem comes in is when you start saying, okay, well, now you're not a candidate for standard pain management approaches, let's say. Oh, well, you have high ACE scores, which means as a patient, if I were a patient, I would say, oh, you're just telling me it's all in my head. So now I'm no longer a candidate for injections. I'm no longer a candidate for standard medications, let's say opioids in this case. You just need to go see a psychiatrist or a psychologist. Okay. Well, again, I think that is all fine and well with the idea that, okay, yes, you do have significant emotional factors to your chronic pain experience, but that doesn't remove the fact that you're still having sensory pain. So it doesn't make sense to eliminate one whole half of your treatment just because you're scoring a certain way on an emotional scale. We do a test here in the clinic that examines your autonomic nervous system. Okay. And so it gives us a lot of different insight, a lot of different numbers. We may talk in more depth on another show, but essentially there's two categories that kind of helps me understand the patient. One is physical stress that the patient may be under, and the other one is emotional stress. And so, okay, there are some patients that actually have really low scores on their physical stress and really high emotional stress. Now, does that mean that all their pain is in their head? No, this is one test on a very complex individual with a very complex history, with a very complex diagnosis that requires an interdisciplinary approach, right? And so this whole idea of this reductionist argument of, well, all your pain just needs one pill, or all your pain just needs, one session with a counselor, or all your pain just needs one injection. That is a very simplified approach to chronic pain management. And if your practitioner is approaching the problem that way, they don't understand pain management. And the truth is, if a patient is approaching their pain in that way, also, they don't understand pain management. All of the literature shows that multidisciplinary care or interdisciplinary care is the standard of care, or it should be, at least the gold standard. Right? The gold standard. So what does that mean? That means, yeah, we have a pain management physician on your case, and they might use different medications to help you. Maybe not just opioids, maybe some other things too. It depends on the type of pain you're having, right? Maybe you're not a candidate for opioids, but you should know why. You should know the reason. And there should be a discussion about that. There may be injections that can help you, but sometimes no. Just like spinal cord stimulation, that may be a great treatment option for you. But, again, you have to be the right patient for the right treatment. And if you're sort of being forced into these, let's call it funnels of care, and you don't really know why, and you're not really getting your questions answered, then I would take that as a red flag. But again, that is the multidisciplinary approach: pain management, physical therapy. Although I happen to think strength coaching or strength training is a little bit better than physical therapy. It certainly as it relates to chronic pain, but that's another story. Now we're looking at, psychology, psychiatric intervention. We're looking at dietitian. You might need another specialist on your case, such as a OBGYN if you have certain female pain problems, or neurology if you have certain pain related to your multiple sclerosis, let's say. So it takes a team approach. And unfortunately, that's not quite what our system supports. And certainly not as it relates to, I think, what the common experience is with patients and their pain management physician. Kevin, you said we had a question.
Correct. I think it's Mark here that asked something about, how do you know if someone's faking the funk?
Faking the funk. Wow,
I summarized that for him too, by the way.
Okay. Yeah. Great question, Mark. So how do we know who's actually in pain and who's not? That can be a whole discussion in itself. And I think I want to do that because it's actually very nuanced. Ultimately, there is no way. That's the truth. The truth of the matter is the patient holds the final say in that. I cannot, regardless of all the tests that we have, say that patient's faking it. Now, there are certain glaring things, right? Like if a patient says, oh, I can't walk on my leg, it hurts so bad. And then, I turn my back and I see them like walking all along to the bathroom, like just fine. That's going to make me scratch my head. So there's definitely some things that may be inconsistent. What that's going to do is lead to more conversation, perhaps more testing, because maybe I'm feeling insecure in our relationship, maybe like the wool's trying to be pulled over my eyes, but ultimately there's really no gold standard. And that's part of the challenge of pain management. Part of the challenge of being a pain patient is trying to get to a point where you feel like your doctor can believe you. But I would say in my experience with my patients, it's the patients that are genuine, that come to the table wanting to do whatever it takes, right, to get out of pain. Those are the people that I'm more willing to go the 9 yards for. And I will say my flags are up. If a patient shows up and they say only one treatment works for me, and that's opioids, okay, my flags are up. Now, that may be a true statement, right? But unfortunately, that true statement in your case aligns with a lot of people who maybe have a problem with these medications. And those are the people I'm trying to not perpetuate into some disaster, right? And so I think a patient who is earnestly looking for help, that's all you got to be. And your doctor should be reciprocating. And I hope that answers your question, Mark. So I would say, again, the system is flawed, right? This sort of brings me to my conclusion point that I want to make here tonight is, okay, well, we know, and this has been well studied, well documented, that chronic pain patients need multidisciplinary care. And the best way to do that is under one roof, right? Because then you have the different specialists talking to each other. And that was my goal here in the clinic that I started 4 years ago, was to adopt a similar model, right? So we're not 100% there, but we're getting there. We have an outpatient, you might call it physical therapy gym, but really it's more of a sports coaching gym attached to our facilities so that you can get your exercise, and it's, you might say, physician supervised, right? Next year, we're bringing on psychiatry and psychology to also help with our patients. So we're trying to recreate what the literature shows is the best model of care. But I would be curious, how many of your pain patients have physical therapy, let's say, attached to their clinic? It's probably not very common. Or even chiropractic, let's say. How many patients, pain doctors, work directly with psychiatry or psychology or even nutrition, right, in their clinic? Probably not very common. I think you might see more of that in larger universities and big healthcare centers where they maybe have the resources to put that together, but that should be the standard everywhere. Otherwise, maybe you're not getting the best treatment or the best outcome. So that's what it should be. But what does the system actually demand, right? And that's how you know kind of where your physician aligns. So we have on one side the government, right? The state. And from my experience, the state wants procedures, right? They don't want more opioid prescriptions. Now, they will argue for individualized care, right? Which should open the door for perhaps more appropriate opioid prescribing. But then they do things like, reducing the opioid manufacturing artificially to create a supply and demand issue. So I'm not real sure that the state wants prescribing. I think the state really wants procedures. Okay, that's over here. Then you have insurance. Now, insurance does not want you to do procedures. How do I know? Well, they make it very difficult to. You have to jump through a lot of hoops to get someone approved for a procedure. And if you don't check all the boxes, and they may not approve it, or if they did approve it and then they do a retroactive review, they find, oh, well, you didn't check this one box, so we want our money back, right? But on the other side, they're going to fill cheap prescriptions all day long. So that's sort of what the physician is fighting up against. The government, which wants procedures, insurance, which wants medications. And that's how you know who your doctor's working for. If you have a doctor that only does injections, okay, he works for the state, right? I think they call them interventionists. This was a whole thing I learned. By the way, where I came from, interventionist was a good word. It wasn't until private practice and hearing from Keith for the first time that, maybe you don't want to market yourself as an interventionist. I'm not an interventionist. Well, not primarily. I'm a pain specialist is how I market myself. But the idea of an interventionist, yes, I do all the interventions. I think there's great things that could be happened with the right intervention with the right patient. But if that's all I would do, am I really a pain specialist? I'll let you decide, but that's the whole thing. So if your doctor only does prescriptions or only does procedures, they work for the state. Now, if they only do prescriptions, well, probably they're going to be shut down soon because the state doesn't want them to do that, right? But that's how it works. Why is it so controversial for you to ask for a doctor that works for you, right? How come your doctor isn't working for you? There should be a combination of prescriptions, of procedures, of diagnostic tests, really figuring out what's going on with you. There should be other specialties brought in. Oh, you know what, Mr. Smith, it looks like, you're a little overweight. I bet if we could lose some weight, we're going to take some pressure off your knees. Rather than just say, go lose some weight, let's help you out with that. I want you to see my sports coach. We're going to do some exercises, and I want you to see my dietitian, and we're going to work on, what you're eating and how we can maybe lose some weight. That should be pain management, and that is a pain doctor that's working for you. Maybe along the way you get some prescriptions. Maybe along the way you get a intervention such as a injection or a stimulator, right? But that is what I call whole person care, and that is the individualized approach. That's what we're arguing for here at Eclipse Unscripted. And I think what's crazy for me at this point is learning how rare that is. It's really rare. I mean, people talk about it, but in real practice, how many pain doctors do you know, or pain clinics that are, let's say, separate from a hospital, which has all of their own protocols, right? How many do you know that operate that way? The system isn't designed for it, but it should be. And that's what we're pushing for here. And I know that's what Keith is pushing for as well. He wants better outcomes for his followers. I want better outcomes for his followers and for my patients. And if you're new to this channel, let's talk some more. Let's have that conversation. What are the challenges you're experiencing? How can we understand each other better? I think that's what would bridge a huge gap in our healthcare system is having these conversations, talking about the elephant in the room. And doctors may disagree, right? I may come to you and say, hey, here's all the reasons why I think this treatment's good for you. Or here's all the reasons I don't think this treatment is good for you. But we're going to have that conversation. And if your doctor does the same thing, that doctor and me, we may disagree. We may agree. They say it's easier to herd a bunch of cats into a room than a bunch of doctors that agree with each other. So that's not the point of, let's say, arguing for better care is that, oh, everybody should get one particular treatment. No. I think what we're arguing for is a more comprehensive approach, a more individualized approach, and an approach that involves the patient in the decision-making. So I'll get off my stump, but that was our live for tonight. Are there any more questions in the comment section? Let's see here. Wow. Hello, everybody. Very good to see all the comments here. Valerie says yes. Was that yes to a question that you had? Okay. I'll wait for a little bit. Amanda Leak, that must be my children. Hey, kids. How's it going? I see you. I'm managing your pain. If you are still hurting, it's on you. Yeah. Oh, wow. Yeah, that's great. I don't even really have a response for that, but probably need a new doctor if that's what they're telling you. All right, guys. Well, thank you so much for joining us tonight. It's been a pleasure. I hope to have more of these in the future. Our next episode with Keith is dropping this Thursday at 7 p.m. And it has been pre-recorded, of course, and I know it's Christmas, so please don't take away time from your family or your loved ones to watch our silly interview. But definitely save it. Come back on Friday. Come back on Saturday and give it a watch. Leave your comments. What did we miss? What do we need to talk more about? Let's keep this conversation going. I'll be back here next Monday at 7 p.m. So let's enjoy the holidays. Merry Christmas. Until then, take care.